We perform sleeve gastrectomies in the majority of patients, but we also perform gastric bypass surgery, and we perform the SADI procedure, or the SADI-S, which can also be referred to as a duodenal switch. The difference between a sleeve gastrectomy and a gastric bypass is that with a sleeve gastrectomy, one would reduce the size of the stomach, and by using a calibration tube to make sure that it's standardized, and that one would therefore what I would call almost perform a virtual bypass, in a sense that the stomach, which is normally a large reservoir, is transformed into a long thin conduit, so that food and liquid would pass through the stomach fairly quickly, as if there's a virtual bypass. A gastric bypass involves making an anastomosis, or a connection between the stomach and the small intestine. The stomach is normally converted into a small pouch, which is then connected to the bowel. It's critical how far down the anastomosis between the stomach and the intestine is made, and we use various fractions to work that out. So we believe it's important that when you perform bypass surgery, that one would measure the entire length of small bowel which is available, and to work in fractions based on that. The duodenal switch is an operation whereby an intestinal bypass is performed in conjunction with a sleeve gastrectomy. And the reason for doing a duodenal switch is that we want to preserve the pylorus, which is the valve that regulates emptying of the stomach. And that has several benefits. One of them is that patients don't get dumping symptoms as often as patients following gastric bypass surgery. And they have fewer fluctuations in their blood sugar levels, and also there's a much lower risk of forming marginal ulcers, which can be a problem with gastric bypass. So in other words, the duodenal switch allows one to overcome some of the problems of gastric bypass surgery, and it can actually allow one to achieve significant weight loss. So it's a stronger operation than a standard gastric bypass. The gastric bypass has its own benefits in that it creates a low pressure system, which for certain patients is desirable. For instance, if they have severe reflux, then a low pressure system would then address the issue of reflux, whereas a sleeve gastrectomy under those circumstances could aggravate reflux. In terms of gastric bypasses, we perform the standard Roux-en-Y gastric bypass, which is the bypass that has been around since the late 1960s, and it has actually withstood the test of time. Surgeons during certain phases in the history of surgery have moved away from the Roux-en-Y gastric bypass, but it's interesting, each time we seem to move back to the Roux-en-Y gastric bypass. It's a very good revisional operation, so if patients have had other weight loss procedures in the past, especially if that leads to reflux problems, the Roux-en-Y gastric bypass is a good fallback option. The so-called Amiga loop gastric bypass, or the mini gastric bypass, is an offshoot from the Roux-en-Y gastric bypass, and it is an operation that is very good in that it is metabolically quite active, so a good operation for patients, for instance, with type 2 diabetes with no reflux. So for instance, a patient who would like to undergo treatment for type 2 diabetes with no reflux could look at an Amiga loop gastric bypass, but on the other hand, the loop duodenal switch or the SADI-S procedure would also be an attractive option. So we perform an assessment, and then based on all of these variables, we can then recommend a particular operation, or sometimes there's more than one, and then the patient's wishes come into play. Some of the operations are reversible, some of them are not. To some patients, it's quite important to have a reversible operation. To other patients, it doesn't matter, or they actually prefer not to have a reversible operation. And that is the whole process of individualizing the treatment so that you get specific results.